For me, personally, Italy holds a special place. I am Malika Shekhar, a haematologist in London, UK. Welcome to my podcast series called The Bitter Pill that looks at lessons that we doctors may learn from history. Italy is a major player in the world of bleeding and clotting. I interviewed haemophilia specialists from Italy in 2019 to discuss the AIDS crisis in their patients in the early 80s. In this podcast titled Italy, we hear from two people. First, from Professor Piero Mannucci, and then from Professor Guglielmo Mariani. Their narrative is about intangible matters mostly, about ideas, memories, and conversations. I went to interview Prof. Mannucci in Milan at the Maggiore Hospital. It's an old establishment, thoroughly modern and a big place. But I had my instructions. Follow the directions to the mortuary. This, of course, was tucked away, but not difficult to spot. Large vehicles and anxious relatives smoking. Opposite the mortuary, on a derelict plot of land, was a port cabin. Prof. Mannucci's office was the first of some half a dozen cabins in this structure. I was excited about meeting Prof. Mannucci for many reasons. His work, his fame and reputation, his interest and impact on the wider world, and he knew the places where I had trained.
Hematologist. So you are a hematologist.
I am. So I went to Vellore to do hematology.
To Vellore.
And my then boss
When
knew
did
very
you go
well.
there?
This was
Did
influenced.
we meet in Vellore?
But
you are from where from? From southern India. So I came to know a little bit about your country.
Our interview had started in the reverse. Why did you get interested in haemophilia as an internist?
That's a very good question.
Then the phone rang. The porter cabin buzzed with activity right through our interview.
I think that's something to do. Ciao. I was an assistant professor in the academic University of Sardinia, but I had a patient with haemophilia, so he could only be treated with whole blood because there was no other treatment, not even plasma. I'm talking of 64, 65. And I could see his problems, how nice he was. The fact that he had endocarditis, he had a big murmur in the heart due to the fact that he had a lot of rotten teeth that of course could not be extracted because of haemophilia. I could witness the fact that during the night he had pain, so I assisted him, but I knew I could do relatively little also to relieve his pain.
So there was this nice man in Sardinia with endocarditis due to rotten teeth. Rotten teeth which could not be extracted because he would have bled badly on account of his haemophilia. Prof. Mannucci discussed this man's story during his research fellowship in Oxford, where he met Judith Poole from USA. Judith Poole had recently described how to produce cryoprecipitate.
When I went to Oxford, indeed, I was very lucky because at that time Judith Poole was doing a sabbatical there. And Judith Poole, she was very kind with me, and I told her the story of my patient. I felt frustrated, I could do nothing. And then she simply taught me in practice, because she taught me how to prepare cryoprecipitate. So when I came back to Milan, at least I had the technique. And so I approached the blood bank here in Milan, and I persuaded them to prepare cryoprecipitate.
Prof. Mannucci returned to Milan and set up production of cryoprecipitate there. Cryo transformed the lives of haemophilia patients across the world from the late 60s until factor concentrates replaced it in the 70s. A bag of cryo was made from 5 bags of plasma. A bottle of factor concentrate from about 1,000 bags of plasma. This, of course, impacted on both the efficacy of the product as well as the infection risk. I then asked Prof. Mannucci about 2 areas where his work was transformative. How do we apply information from a new development in the treatment of our patients? The term for this is translational research, from the bench to the patient, from the patient to the population. Let's hear his account of using heat treatment of pooled plasma to inactivate HIV.
Okay, well, the answer is very simple. First of all, the data had to be confirmed because when the paper came out, the Journal of Clinical Pathology, I remember that some people with the blood sample put in ice, in crushing ice, close to my water bath, when I did the clotting test, the idea of heating a factor VIII concentrate was disturbing because we knew it was a very labile molecule.
So a new idea has to be plausible. Factor VIII was labile. In the diagnostic lab, you would keep the plasma samples in a cold temperature while doing all the assays. So heat treatment of plasma to remove HIV could damage the factor VIII. It would actually be a case of throwing away the baby with the bathwater. It's a difficult idea, but the data were encouraging.
Anyway, what I wrote was first that Montagnier had developed a test for LAV, that was called leucinated virus, and also that there was a paper that did show from the virologist that the HIV, it was labile, very labile to heating.
Then, a turn of events where apples and oranges can meet. In this case, Hep C and HIV. So before HIV, there was hepatitis. Hepatitis B was controlled because there were tests, there was a vaccine. But non-A, non-B hepatitis, or Hep C, was a pernicious problem. People had been investigating heat treatment of plasma to get rid of Hep C. It didn't work for Hep C. Prof. Manucci read a virology article about HIV's susceptibility to heat. It can be killed by application of heat under very specific conditions. So can heat treatment for Hep C be repurposed for HIV? And importantly, how to prove that HIV has been killed? So when Luc Montagnier has the first ever test for HIV, or LAV as it was known then, Prof. Manucci carries a bag full of samples to Paris.
So what I did, I went to Paris. I remember I met Montagnier in a cafe in Boulevard. And I told him, listen, I have here this sample of this patient that were virgin from any previous treatment. They all developed hepatitis, and the heating test the sample, and none of them. And it was a letter published in the Lancet, because this happened in November '84, when already the thing had exploded, but not to a great extent.
So the patient's samples in his bag were all Hep C positive, but amazingly, HIV negative. So heat treatment was repurposed for eliminating HIV from plasma. We then spoke about his idea of using DDAVP, an analogue of vasopressin, as an adjunct to treating milder forms of bleeding disorders. Again, this was important work, and again one that he was already doing to counter the hepatitis C threat. Early 80s, people must have been actively thinking, how can I avoid using factors? The advantages of DDAVP was clear, but the uptake was very mixed.
DDAVP?
Yeah, so some countries used it, some didn't.
I got involved in the story of no replacement product like DDAVP because of the story of hepatitis. I was very silly because, believe me, so if I had obtained a label for the indication that was understand, I could have made some money. I didn't do because for me the most important thing was to publish the paper. The data had to be confirmed. It was the Scottish that did not confirm the data. And then there was Ilsley who wrote a letter in which he said, confirm that. Then there was Jill Lusher that was the first in the United States to use it. But see, many people were not convinced that it was a way, even say, to treat haemophilia. So to be accepted, an idea has to sound plausible. Then serendipity has to connect apples and oranges. Then the scientific challenge of having your data reproduced and confirmed by other labs. Then overcoming the bias and reluctance of the medical fraternity. And finally, implementation. In the case of these two technologies, heat treatment and DDAVP, this took a couple of years. Unlike Judith Poole's formula for producing cryo, which was something many centres adopted quickly. So now the technique of heated concentrate is available. But how does it get implemented in Italy? In terms of your lobbying power within the country or within your institution, did you have much support to bring about whatever changes you wanted? No, I wouldn't say so. It was in July 1985 when the ministry released the recommendation. It was not obligatory, but they recommended very strongly not to use any longer the unheated concentrate. They didn't recommend specifically to throw them away and to use the heated. Of course, I'm sure that many continue to use it. So there has been some cases that I'm sure became infected afterwards not because of the failure of the heated concentrate, but the reason was that it was a strong recommendation, but it was not made mandatory. In my opinion, it was done timely, but not strongly enough.
This hesitant approach to implementing heat treatment meant that people contracted HIV even while heat-treated products were being introduced and distributed. Logistic problems like these are very hard for families and for doctors. There's a sense of frustration and helplessness as things go wrong, in spite of solutions being available. In military settings, and more recently with the COVID pandemic, the term moral injury has been used to describe the state. I then asked Prof. Manucci about the perception of risks in the early days of AIDS. He described his conversations with two presidents of the World Federation of Haemophilia, both of whom were on factor concentrate treatment for severe haemophilia. Frank Schnabel, the founder-president of the WFH in 1982, and Charles Carman, the president in 1987.
I saw two presidents of the World Federation of Haemophilia dying with AIDS. The first was Frank Schnabel, and then there was Charles Carman. In July 82, there was Frank Schnabel that asked me, I have some kind of fever and I have some enlarged lymph node. I did palpate his neck, the lymph nodes were palpable. The fever was oscillating. I said, well, it's worth it to be explored. Maybe you have a Hodgkin disease. They both told me independently and separately the same thing. I don't like to die, but I can tell you that if I went back, I would do what I did, because the advent of concentrates in the 70s changed my life dramatically. And they died in their 60s, and I'm not happy of dying, but certainly I don't regret, je ne regrette rien. They said really that, both. Not everybody, of course, thought in that way.
This narrative is representative of many haemophilia doctors' situation. There was a general agreement that patients and doctors thought it best to carry on with effective treatment, as the risk of HIV was uncertain. There were individual conversations, but often these were collective assumptions. As Prof. Manucci said, not everyone shared the same values. We will end with Prof. Manucci's account of how this whole period affected him. His younger colleague takes over the clinical practice, and Prof. Manucci develops a different clinical and research portfolio. This happened in many centres where younger colleagues who were less involved in the original treatment decisions took the clinical practice over and were able to provide a fresh start.
Well, there are certainly some people that have some anger. The reactions are different. The patients were not angry with me. On the whole, in this country, I would say in general, they are not particularly angry. In the States, the anger was much stronger. In Europe, the only victim was really Jean-Pierre Alain.
I can understand now that because HIV started late in Italy, the communication with patients might have been a bit easier because the test was already there.
First case of a clinical AIDS, 1985.
Yeah.
Now we are lucky in that respect.
Yeah.
And also for some reason, the infected lot reached us early, but a little bit later than in UK, England, and France. So lucky, just lucky. For example, a lady, she was really on the edge of the tomb, and she was saved by the first highly active antiviral agent. But that was really in the space of 2 or 3 months that the thing changed. I was a wimp. Originally was younger, less involved originally, and so I did relinquish the dealing day to day, because for me it was really very difficult. When I saw all these kids that I've seen and doing skiing, When I saw these kids, that was terrible for me. It was terrible, but it didn't stop me, but certainly I was very sad. And so, again, I don't feel guilty, but I feel very, very sad for what happened.
Italy, like some other European countries, didn't experience high level of public anger. It was lucky that AIDS occurred later. By 1985, there was a test. Heat treatment was being implemented. By the early 90s, effective drugs for AIDS were starting to be used, and Prof. Manucci's patient was pulled back from the edge of a tomb just in time. I interviewed Guglielmo Mariani in summer 2019. Prof. Mariani came to meet me in my windowless office in London one very rainy day. He's retired now in the Dolomites. In the early 80s, he was in Philadelphia doing a research fellowship.
And exactly on that time, AIDS was blooming, if I can use this verb. And I was living in the neighborhood where the homosexuals were living, which is Chestnut Street, that area. There were many homosexuals, but there was my apartment, and I had many friends. And the year after, when I returned, many of them were no longer there. It was exactly the same story of Philadelphia. And the people,
movie.
Huh?
The movie.
Of the movie. And people were scared because even physicians didn't know what to do. And even worse was the attitude of the families of these people. They didn't want to see their sons because they had AIDS. And they were dying alone. And not all of them, but some families had this very disruptive attitude. And so sometimes they were dying together with their friends, because they became infected together. They knew I was a physician, and they was asking me, what's this disease? And I said, I participated in a number of meetings. I went to the CDC, I went in Washington and in Philadelphia, but no one knew what was the causative agent.
So this was 82, 83?
82, that was 82. In 83, things were changing. So I remember that it was called the 4-H disease, and then there was no connection between these populations.
The 4-H disease is a descriptor for AIDS, hemophiliacs, Haitians, homosexuals, and heroin users, the 4 groups who were particularly at risk from AIDS. Prof. Mariani describes the first patients with AIDS that he saw in Rome back in 1977, 5 years before AIDS was first reported in USA. These diagnoses were ones that he made in retrospect.
But before this, I observed a number of patients that were terribly puzzling. Because the first patient that developed AIDS was a guy who had an inhibitor and was treated with the ITI. That was in 1977.
Yeah.
And I observed a terrible lymphopenia I couldn't understand. He was living 300 kilometers far from Rome, but we kept in touch. He called me frequently and so on. So I missed him, and I called the family, and they said he's died of pneumonitis. That was 77.
So he died in 77?
He died.
The ITI refers to a protocol that was developed in Bonn. At that time, inhibitors to factor VIII was a big problem. Patients treated with factor VIII developed inhibitors to the protein in the factor concentrate, which meant that they became resistant to factor VIII treatment. So the idea behind the ITI protocol was that you induce immune tolerance and the inhibitors can then be overcome. This meant using a lot of factor concentrate. How did Prof. Mariani think about the connection between his treatment using factor concentrate and the development of early cases of AIDS in his patients?
And then there was another one who developed a lymphadenopathy. I thought it was a lymphoma. I was convinced it was a lymphoma because he had a couple of big nodes, 2 to 3 centimeters and so on. So I asked to do a biopsy, which was done, and the pathologist didn't know what it was. He couldn't tell. Because there was, on the one side, there was hyperplasia of the lymphoid tissue, on the other side, there was necrosis. I've never seen this picture. After the first guy developed lymphopenia, I called Hans Brackmann in Bonn, and I asked him, have you ever observed this lymphopenia? He said, well, I know that lymphs go down, but I never been concerned about this. But in this case, lymphs were below 500. So the story was probably quite different from the one in.
So 2 patients in Rome with unexpected problems before AIDS was reported in the medical literature, both treated heavily.
When did you first realize that this was treatment related?
Well, I think later because lymphadenopathy, there was no reason to think that it was treatment related. The lymphopenia I interpreted as an immune system overload by proteins. That was just a guess, but I couldn't explain it otherwise. This guy with the lymphadenopathy, years later, he came and he said, "You knew I had AIDS." No, I didn't. I was unable to tell that was AIDS at all. But you took my note. You should have known that I had the virus inside. You know,
How would you introduce the problem
to the patients? Well, they already knew because they were coming and they were saying, what's going on?
Okay.
Our group of patients, our community has this problem. Some of them were angry because I have nothing to do with the homosexuals. Why is people connecting my story with that of homosexuals? And it was frustrating because we weren't able to answer correctly.
So what would you say? How would you explain it?
We said that probably there was something that was inside this concentrate that could have been the causative agent of the nightmare that was invading Europe and the States. And that was in the concentrates. And they were asking, and the homosexuals, they don't take concentrates. So it was difficult to explain about.
Patients seek to have a name and cause of their illness, but many also have a why question. Why me? Why now? What did I do wrong? Patients amalgamate information to build their own explanatory models. Haemophilia practice in the 70s and 80s did not usually use the war metaphors that cancer used, but we see here the use of the phrase, a nightmare invading USA and Europe, that Prof. Mariani uses.
They had been asking for meetings. In those meetings, many hemophiliacs participated and their families as well. And so we started discussing the issue and so on. And they knew that I had been in the States, and so they thought that I was more knowledgeable than others.
Or were you? You could have been.
Well, I wasn't. That's the story. Because when I participated in those meetings in Philadelphia or in at the CDC and so on, it was a nightmare of discussions of different hypotheses, of different proposals and so on. So no one knew. There were so many problems all together, which we weren't able to connect one another, apart from the fact that the causative, not agent, but the causative product was phosphorate concentrate.
Everywhere, people sought expertise from colleagues who had travelled, worked in America. It was important to have gone to USA and returned. HIV, Hep C, inhibitors, new technology, different products with different merits. There were many simultaneous things going on at that time.
So you put it very, very well, that there was a lot of things happening simultaneously.
Yeah.
During that time, we were still looking after the patients, and the patients also agreed that they shouldn't change how the treatment was being done. But during that period, did patients still trust you because things were continuing to go wrong, but people had no solutions to it, no explanations for it? Did they find it harder to be your patients?
Well, at a certain point, patients started to disappear. It happened in Rome, in Milan, in many centers. And we started asking what was going on and why. So I called them, but calling patients is always a little bit. I felt uneasy to how are you, knowing that there was this big problem behind. And so they said, even if I come, what's the difference? They said, well, there are new concentrates. Now the treatment of concentrates seems to be very promising, but if I already got the virus, yeah, I know that, but probably continuing to give new virus might be worse than treating you with safer concentrates. We didn't know that this wasn't and we tried to convince him to avoid this disaffection toward the center and toward the treatment.
We've heard many snippets of details, how his patients perceived him, the treatment and the institutions, and how he worked around that. A doctor from Australia told me that he would drive through hot scrubland with his nurse over 100 miles to check on a boy with haemophilia, only to be barred at the door by the boy's mother, who wanted nothing to do with any treatment, or indeed treaters. The Italian experience is less hostile when compared to the Australian. But dropping off the radar is a major hurdle to health in patients with chronic conditions everywhere. Deaths due to HIV rose through the 80s, but in many parts of the world, deaths due to bleeding also rose, due to worries about using concentrates or cryo. Let's move back to the WFH. The WFH has a twinning program. A wealthy country is twinned with a low middle-income country. This was Prof. Mariani's brainchild. I asked him how this came about. For an answer, we moved to Somalia with him.
Then there was a very nice experience. The National Institute of Health asked me, they called me, they said, we know everything about the epidemiology of AIDS in West Africa, but we know nothing in East Africa. And I had spent, that was 1977, 6, 1 year in Somalia teaching hematology.
Ah, okay.
So I had friends there, and they said, well, what about if you go to Somalia and check for AIDS in Somalia? I said, well, why not? It was terrible and marvelous experience because I had to travel from village to village to take blood, to convince people to give me a specimen of blood. And I was backed by a Somali physician, and there were 4 soldiers with the guns, and we had 2 Toyota, and traveling in the middle of nowhere. I went to the border of Ethiopia, went to the border of Kenya, and so on, from village to village, and we collected some 10,000 sera. People were rather cooperative. I was really astonished about the cooperation. We started talking with the chief of the village, and they said, okay, I will, provided you tell me what will happen after. Don't tell anything to the government, these stories are common. And we found only 1 case in 10,000 sera.
Right.
And the guy was a lorry driver who went through Africa, but there was only 1 case. Till the Civil War, and the United Nations sent international army there, so on, and AIDS bloomed out.
Right.
Thousands of cases.
I see.
So Prof. Mariani has a relationship with Somalia which started well before AIDS, continued through the 80s and after. The twinning program and his EU program were conceived from this experience.
Can I take you to the WFH initiative you did with the twinning program?
Yeah.
So that was very unique and people benefited a lot. What made you take that approach?
Because in Somalia,
Okay.
I had treated some hemophiliacs
Right.
with plasma. And I had a friend there, and he was the local hematologist, and he said, why don't you continue helping me when I returned to Italy? I said, well, I can do that, but I don't know how to send you concentrate and so on. I said, go on and produce plasma, but I don't have the centrifuge, so I provided with the centrifuge. It was a nightmare sending a centrifuge to Somalia, but finally 6 months later arrived. And so we started treating patients with the plasma and so on, but for them it was a great success.
Yes.
And so I thought, well, let's conceive a program with some specific features, and twinning was the most apt word that it came to my mind. And so I proposed a program, and then it was well accepted, became widespread and so on. So it's, well, I'm glad that
Yes,
We conclude this extract with Prof. Mariani's reflections on his emotions on realizing the iatrogenic nature of AIDS and his observations on this period of his life.
But did you ever have to apologize to anybody for it? Do you think guilt was a big feeling?
Well, the first patient who died of AIDS because I treated him with the ITI, I still feel some responsibility, because I was interested in ITI, and that was probably my well, I had 2 or 3 patients, and I convinced them that getting rid of the inhibitor would have improved their lifestyle and so on. So,
What advice would you give to people now with the knowledge of what happened?
well, probably I wouldn't have treated them with the ITI. Sad. Even though, no, I wouldn't have treated them with the ITI.
Not very many
It
options.
wasn't an amount, it was a problem of amount of concentrate, it was a problem of quality of concentrates. But patients got the AIDS even in on-demand treatment.
So, given what you went through, what advice would you give to contemporary doctors about dealing with problem situations like this?
What will I say to him or to a doctor? Maybe to be cautious, maybe to be more cautious, maybe. I don't know if it is a matter of cautiousness, but still you have to treat them. Treating was certainly necessary, and what was, I would say, pushing us to continue treating them, because the patients didn't want to return back to the pre-treatment era. It wasn't much our advice. They didn't want to return to experience the pain and the sufferance that they had because of haemophilia. So this explains enough my lack of guilty, or my never felt guilty profoundly, but certainly I had some very difficult moments. I see some of them even to today before me.
Others have felt similarly, I have to say. But it seems to me one of the things that helped you during these years, it seems, is you stayed on in it, and the research interest and trying to answer questions actually was probably something that kept you going. It seems. Would you say that?
It's true. Because that is a positive attitude.
Yeah.
Research is a positive attitude. It's looking for something new, looking for explanations, looking for answers. Yeah. And this certainly is the positive part of our profession.
So sadness is the prevailing emotion in both the narratives. Sadness and difficulty in continuing to deal with a post-crisis clinical practice. A nightmare scenario of uncertainties that went on for a long time. The stuff of nightmares was how Lord Penrose described the doctor's situation in his inquiries report of 2015. But both Prof. Manucci and Prof. Mariani sought value in being part of the solution to a terrible problem, through science and through collegiate networking. We therefore end with the most powerful emotion of redemption, that you are redeemed by being part of the solution, in a wider global sense, if not to individual patients. Thank you for listening to this podcast. Goodbye.